Dr. Sanad is a consultant and an associate professor of cardiac surgery, Mansoura University Hospital in Mansoura City in Egypt. And he's, again, another new user for AVNeo. And he's going to tell us about his experiences. So Dr. Sanad, please take over.
Okay. Hello, everybody. I'm Dr. Sanad. I'm from Mansoura University, Egypt. First of all, I want to thank Dr. Ozaki for his this excellent, and I think it's an innovation which will change the aortic valve procedure for the aortic valve disease patient. And also I want to thank Joint Company for this kind invitation for this prestigious webinar, and Dr. Crane for his continuous support. And special thanks to my colleagues and my friends in Mansoura University staff, surgeons and junior staff, also for the physicians, for the nursing staff, perfusion and anesthesia team. Congratulations, Dr. Fukuhara, for his nice results and his brave heart to start the Ozaki technique, especially in the infective endocarditis patients. We are now all in unsettling times due to the COVID-19 virus, which is clearly impacting our personal and professional life, and also affecting those who are in love. I want to wish you and your loved one and fellow colleagues safe passage through this difficult period of time. What do we need for the patient with the aortic valve disease? We have to look forward a lot of factors that we have to choose before putting a valve in the aortic position. We are looking forward the durability of the valve, the anticoagulation use, what about the effective orifice area of the valve after surgery, and the complication related to the use of this kind of valve. Also, the risk of reoperation, maybe we have to put in mind and to have to wait before putting the valve in the aortic position. We have a lot limited options for the aortic positions. First, it may be the mechanical valve or the biological valve. The mechanical valve have a lot of complication, as you all know, that the anticoagulation use and its complication. Also, the tissue valve, the durability may be questionable. The TAVI is a good option and minimally invasive option for the aortic valve replacement, but we mean use it in very old patient, and we have a lot of concern about the cost regarding the TAVI, especially in a developing country like Egypt. The AVNeo or the Ozaki procedure have a lot of advantages to our community. Especially, we doesn't need to have the anticoagulation and its problem, and also it can be used in all ages of the patients. The complication as regard the permanent pacemaker or the cerebrovascular accident are much less, and the cost is nothing. The main pathology of the aortic valve disease in Egypt is the rheumatic pathology. It's a more destructive and less repairable option, but it affects, it's not only the old patient, it affects the young patients also. Due to our loss to the low socioeconomic status of these patients, make the tissue valve and the Roche procedure and TAVI are difficult to be afforded, especially for most of the patients. The Roche procedure, as Dr. Fukuhara said, it may be a highly demanding operation. It may be taking a long care for training, and also it may be costly somewhat as in comparison with the other options. Due to the low educational level of the community of the rheumatic heart disease, which allow the patient to, which make the patient not compliant to the anticoagulation medication and increase the rate of valve-related complication and anticoagulation side effects. So the AVNeo, or replacing the valve with the patient's own tissue, seems to be more suitable in our community. The advantages of the Ozaki include a lot of advantages. It may preserve the native annulus. It preserves the native annulus, which allow a larger effective orifice area in comparison with the tissue of biological valve and other mechanical valves. It have a larger coaptation zone, so it can be used in the pediatric age group, which allow the growth of the of the patient and with the same coaptation zone. Also, it enlarges the orifice area of the patient, especially in patients with a bicuspid valve through tricuspidization. And it is a promising alternative in the light of limited resources. We faced a lot of challenges before starting the program in our country. There is no past experience in the region, not only in Egypt, in the Middle East or Africa. The AVNeo set is not available. And there is a lot of negative energy convincing the heart team, administration, competitors. Pericardial preservation technique and lack of glutathione 0.6, it concerns a major issue to us, just to bring the glutathione from outside and starting the program. The Ozaki technique have a longer bypass time compared to the valve replacement techniques. And there is no worldwide long-term outcome published up to date. Although these all challenges, we have a positive aspect, which encourages us to start this program in Egypt. Promising published early and midterm results, institutional cost reduction policy as regard the biological prosthesis and Contigra or something, or the valve conduit, and also the hospital cost analysis of the Ozaki procedure in comparison with the biological valve, which weighs a lot and encourages the Ozaki procedure to be started. Training was a very challenging one and gives us a very positive aspect and very positive experience, as this technique has a short learning curve, more reproducible, and give us a lot of positive energy to continue and to encourage and expand our experience. Early patient satisfaction is a very positive energy, gives us a very positive energy, as there is no need for anticoagulation with a rapid return to the patient full activity, especially in the young patient. We consider the Mansoura University the first university introducer of this technique in Egypt, Africa, and the Middle East. We started our journey in 2018 by orientation of the heart team, also to weigh the cost of this procedure and the setup, institutional approval before starting the journey of Ozaki. In April 2019, the equipment and set is almost complete. I did training with Dr. Crane in Munich in April 2019, and we started the first case in June in the same year. Dr. Crane has visited our center in February 2020, and now in August 2020 we have almost reached about 20 patients operated with Ozaki operation. The mean age of our patient is ranging from 21 years old up to 65, with a mean age of 39. The body surface area is ranging from 1.5 up to 2. We have 6 patients of our patients were female and 14 with male. NYHA classification was in 4 of our patients and 3 in 16. 50% of our patients has a severe AR, and 50% of them have a mixed, either isolated AS or mixed AS with AR. The preoperative echocardiographic data showed the peak gradient with the mean 53 millimeter mercury, aortic valve area 1.7, and the mean pressure gradient was 35. Annular size, the mean annular size was 23. 4 of our patients was with bicuspid valve type 0. 16 was with the tricuspid valve. About 10 patients have heavily calcification. One of them have a small annulus. One of them have a supraannular stenosis. One of them has an extensive calcification extending up to the LVOT. The cross-clamp time almostly was 146, which is maybe longer than the regular valve replacement techniques, and the total bypass time was 180 minutes. Where the ranges sizes of the Ozaki set range from 23 size up to 31. There's some photos from our results and some of our patients and the intraoperative results, final results. This is now the echo data intraoperative TE, which showed the longer coaptation area, as you see on the left side. Also, this is the LVOT opening with the same, almost the diameter, the AVA diameter almost the same with the LVOT one. There is no restriction of the annulus. Good coaptation, no AR, and also the pressure gradient on the right side, which showed that this minimum pressure gradient, as you see on the left side, the left echo with the characteristic Mercedes-Benz sign of the aortic valve appears in this echo data. There's some photos of our echo intraoperative TE, which showed the longer coaptation zone. Also, there is no AR. The complete opening of the valve, which showed the LVOT size, which is mostly the normal one. The operative data, intraoperative TE, showed that the mean gradient, peak pressure gradient was 16, and the mean pressure gradient mean was 7.6. Aortic valve area ranges from 2 cubic centimeter up to 5, and we have 17 patients that don't have aortic regurg, with one patient with a mild AR and 2 with trace. The post-operative results, including the ventilation time, which ranges, the mean ventilation time was 3.3 hours, and the ICU stay was 1.6 days, and the total hospital stays was 4.2 days. We have some challenging cases. One of them, we have an undiagnosed is the preoperative. The preoperative is not diagnosed by echo, and we diagnosed it intraoperative by finding some in the venous line, and we managed it by closure directly. One of our patients have a pericardial tear after sternotomy from the sternal saw, but we complete the operation by using the pericardial on either side, the right and the left side, and we use it for the 3 cusps. We have a patient with heavily extensive calcification extending into the LVOT. Meticulous decalcification was done to this patient, and the Ozaki was done to him. We have 2 patients with a high drainage, ranging from 1.2 liter up to 1.4. We have 1 case with a late post-operative diaphragmatic paralysis after 3 months of the operation. We have 1 case also with a post-operative psychosis, and one of our patients developed spontaneous pneumothorax after 3 months, and the CT shows a large lung poly that was not diagnosed pre-operative before the Ozaki operation. Our echo results after 1 month showed that the aortic valve area, mean aortic valve area was 3.4, with a peak pressure gradient of 9.8, with a mean gradient 5.7. 18 of our patients doesn't have AR, and 2 have trace AR. After 3 months, the AVA surface area, the mean AVA was 3, ranging from 2.3 up to 3.6, and the peak gradient was 13, mean gradient was 6.7. There is no patient with AR. None of these patients developed an AR after 3 months. We conclude from our series that the Ozaki program was a challenge that provide us with a reasonable alternative for the aortic valve replacement using biological valve. Is almost not costly at all, except the setup, and there is no prosthesis needed, there is no anticoagulation is needed, and the equipment is reusable, so it gives us a lot of, it will reduce a lot the cost very well, and also it will be suitable for all ages, can be applied in various pathologies, avoid the complication, as I told before, of anticoagulation, and with a shorter learning curve. And it can be used through a minimal invasive approaches. And also our colleagues in the pediatric unit, we may use it in the pulmonary position or start this program sooner. Patient satisfaction is a very challenging and very promising. We follow up our patient meticulously, especially after surgery, and up till now we have a patient more than after the patient by 1 year. Almost this patient has a very satisfactory results and very satisfactory physical activity. Thank you very much.
Yes, Dr. Sanat, thank you very much for this very, very nice presentation. And I remember your visit in Munich very well when you came a little bit more than a year now. And you have been very, very motivated to do this procedure at home. And I remember that very well. And it's fascinating to see that today you have already done 20 successful cases in Egypt. And I have had the chance to visit your wonderful place there over, and all the new equipment you have got and so on. So congratulations on that. So you won through this whole process, getting your training outside and so on. What have you been missing during that time? Do you could imagine that there could be more support from the company, more support during the training to start a program? Do you need or would wish to have more support in your institution or something like that?
To be honest with you, Dr. Crane, the training was very short while our visit in Munich, but I think with a trained surgeon and a well-experienced one, you can reproduce it and start the program immediately after taking the training. It allows you that you can start immediately after the training. That allow you that you have a chance to do it perfect. And you explain to us every single details and surgical tips and tricks of this technique. So almost we have to take the risk and start the program immediately after coming back from Munich. This is my opinion and my advice to the junior staff that this Ozaki technique, it can be done. It's a very good chance to our patient, especially it's a very short. It have a very short learning curve, and it allow us just allow us to just to start this technique in our center, and immediately use of Ozaki to our patient and to give benefit to the rheumatic heart disease patient.
Okay, what is about the second part of my question? Do you wish to have more help from, for example, the company with institutional problems?
From the institution, we have some support. As you know, in Egypt, we are not working in the same in one hospital. We are working in more than one hospital. So it can help us to do a lot of patients in different sites. For the university, support was very helpful to us. And as regard the company is very helpful. Just they give us they help us in the setup, and also they help us in providing the glutathione of 0.6, which was not available in Egypt. Some more training, it may be add something, especially in the bicuspid aortic valve. I'm especially in the type 1 or type 2 bicuspid valve. We may need some more and more training.
Okay. Last question from my end to you. How does the optimal patient looks like from your opinion for the first cases? We discussed that question with Dr. Fukuhara. How is your opinion about that?
About what, Dr. Krim, please?
How should be the first patient or the first 5 patients if you want to start a program? Tricuspid, bicuspid, high BME, low BME, whatever you want to say.
My recommendation is start with the tricuspid valve. Never start with the bicuspid valve. I have oblique to start with the bicuspid valve after I open the valve immediately and preparing the pericardium and everything. So I have to do it. I cannot come back. This is my recommendation, that you have to start with the tricuspid valve, and you have to do more and more surgeries, even every 1 to 2 weeks. You have to do one surgery with one Uzaki. My recommendation to the young surgeons, that you have to start training from now. You have to search for the centers that have started Uzaki already, and you have to join them and to start this technique, because one day it will be have a good chance, especially in our country.
Okay, thank you very much. Do we have questions from the audience?
Yes, we do have several questions for Dr. Sanad. So Dr. Sanad, the first question for you is, when dealing with extensive calcifications in the aortic annulus, do you have some precautions in suturing the new leaflets?
Yes. We have, when we do the extensive calcification, we have to be cautious that we doesn't injure the annulus, from my point of view. Just don't, you can leave a little bit minor calcifications that you can injure the annulus, because as you know that the suture the pericardium are suturing to the annulus itself. So you have to keep the fibrous part of the annulus almost intact. For the decalcification, we do it as much as we can, but almostly we doesn't leave any calcification in our patient. For this experience of the biological, for the mechanical valves, or for the Uzaki also.
Okay. Great, thank you for that. Second question is, how did you manage to solve the problem of 0.6% glutaraldehyde? Somebody's asking because they don't have.
I get it from Amazon. Firstly, I get it from Amazon, and then we have to prepare it here from in Egypt. I get the prescription from you, Damon. Thanks a lot for your support, and also from Dr. Krim from German Heart Center Munich. And we send it to one of the centers here in Egypt, and now we develop, we prepare the pericardium, the glutaraldehyde 0.6.
Okay.
One have to say, I guess the glutaraldehyde is often a problem in different countries.
Yes.
So, up to my knowledge, it's also a problem in the UK, and that they are not allowed to use it, and so on. So to have a maximum of support coming from JOMDD to solve this problem into the different countries is probably key to get more centers engaged in this procedure.
Yes, we have, we've worked with a number of different centers to try to help them secure the 0.6% glutaraldehyde. We have a couple of sources that we can get that shipped directly to hospitals around the world. So we can definitely help. But usually, like they did at the German Heart Center, the pharmacy has the capability of manufacturing the right concentration
yes.
in the hospital. So that's always a good option. Okay.
We hope that we can prepare it in our university in the next few months. We have started already to contact the person here in the pharmacy, and we hope that we can prepare it in the next few months. Yeah.
Okay, great. Another question, if there's a mild aortic regurgitation at the end of the case, what would you do? Mild AR.
It's a questionable regard. I think that because the echo, some views that show that it is a mild AR, and almostly it may be trace. So we, I don't recommend just to come back to extract the pericardium and put a biological valve, and meticulously we follow up our patient even every 1 month by an echo, and the result was satisfactory.
Okay, great. Next question that we have is for Professor Crane. Professor Crane, they would like to know what would you say to a cardiologist to convince him or her about your indication to AVNeo versus a biological valve? This is a very important question, I think, for people starting the AVNeo procedures, is that they obviously need to get the support from the cardiologist in order to get the referrals to be able to do this procedure. So how did you go about educating them and convincing them that AVNeo was the right alternative for their patients?
So this is really a key question, and I'm very thankful that one of the audience asked that, because probably in every kind of country, it is the same, that the patients are coming from the cardiologists. And if the cardiologists are not satisfied by your operation, they just will send it to another cardiac surgeon, and then you will lose your patient. So to convince them that this could be an alternative means that you have to show them the limitations of all other given treatment options. In Germany, we try to talk in different ways to them. So we are very much into this TAVR procedures. So in Germany, usually people who are younger than 75 or up to an age of 75, if you are older than that, you will receive a TAVR procedures in Germany. So all these older patients are completely out of this discussion, what kind of procedure they will get in the future. So what is left over is the younger patients around 65, 60, or even younger, when you are starting to discuss about a mechanical valve. So, and here we need definitely different new options. The mechanical valve is, you have seen during the last publications that a mechanical valve doesn't have to be so bad, but all of us, we know there's problems with anticoagulation and so on. So what is to do with a 45-year-old patient, for example? A 45-year-old patient receiving a mechanical valve, having been on Macamar or Coumadin for the next 40 years, and definitely will have a bleeding issue during this time, or at least at 30 to 50%. So, and if you argue with your cardiologist about this kind of patients, so younger patients between the decision mechanical valve, biological valve because of lifestyle issues and so on, then cardiologists see that we have to find a solution for that. So this is one point, that we have to focus on a patient population which we want to target. And in the German Heart Center, we try to target this kind of population. So our mean age in our 150 or even a little bit more patients is, the mean age is below 55. So you can see we treated some who are older. This is because of a study design, but the majority of our patients are in this range of 40 to 50, 55 years old. And the cardiologists need a solution for that. Then if you have a look at the post-operative echo, and you have seen that in the presentation from Dr. Sanat, the valve looks like almost in some echo presentations, like a physiological valve. So you can convince them in the way that they see the result. And if the result is very good, a lot of cardiologists called me after an operation when we transferred a patient back, and he told me, oh, this is fantastic. I couldn't see that that you did an operation because the valve looks so physiological. So this could also be something to convince cardiologists. What is very important is to talk to cardiologists, to go to them, to talk about the procedure, that there is a new one, that they are not surprised, that they will find a valve which they are not thought about. So you have to tell them that this is an alternative and that you can offer that additional to the other procedures which are already established. So this is a little bit a strategy, talking, having good results that they can see in their own patients, and to have a very good definition which kind of patients you want to treat. So in Germany, we never would treat a patient who's 77 years old with an Ozaki procedure. That makes no sense from my point of view. Another point is, coming back to the TAVR, it could be, there's no proof of that, but it could be that you can implant a TAVR prosthesis into an AVNeo. It could be that this works. So there's one published case out there. And if you have the strategy that you are able to put in a TAVR prosthesis into an AVNeo, again, there's no proof out there that is possible, but if this is possible, then you probably have the possibility to do that twice, because the first TAVR procedure goes into the native annulus, and the second one could go as a valve-in-valve into the first TAVR procedure. That means you can do, you can expand your time from reoperation, from open heart reoperation, and perhaps a 45 or even 50-year-old guy is able to be never operated again if the first AVNeo was very successful, and then you have the option to do twice the TAVR procedure down the road. So there are a lot of arguments you can tell your cardiologist to convince them. This is just a part of that, and now I want to stop talking because it was already perhaps a little bit long.
No,
but this is a very, very good question.
Yes, and then your answer is very, very important for everyone to know, that the cardiologist is obviously very important part of the overall team, and to have
Yes.
a good working relationship with them is very, very important. So thank you for your answer.
It's absolutely crucial to work together with them into a heart team.
We have a very good positive feedback from the cardiologist after the surgery. They encourage us to do more and more. They send now the patient for Ozaki and the aortic valve reconstruction. After seeing the valve by echo, they told us that it's like the normal valve. Some of the cardiologists doesn't notice the difference between it and the native valve. They consider that the patient doesn't do the operation.
That's a very good point. So Dr. Sanad, another question for you. Can the AVNeo procedure be done for a rheumatic heart disease with mitral and aortic pathology? And if yes, what will you do for the mitral valve if you have to replace it?
I have to put a tissue or a biological valve in the mitral position. We have a patient with a questionable mitral regurg and the mitral stenosis, mild to moderate, something like that. When we do a both intraoperative TE, we find it mild. And when we open the aortic valve and assessing the mitral valve from the aortic position, we find it like almostly a good valve. So we doesn't do anything for the mitral valve. But just in case we have to do something for the mitral, I put a biological valve.
Okay, great. Then there's one question about the ortotomy. So are you doing oblique, or are you doing a complete transection?
Transection for what? For the ortotomy?
Yes.
Yeah, I don't do a complete transection. I just do a transverse aortotomy and keep just one to 1.5 centimeters attached to the aorta.
Okay.
So that's the same what Ozaki is recommending. So he's recommending that you just do something like 3/4, and the
Yes.
aortotomy should be 1.5 centimeter above the right coronary ostium.
The RC, yeah.
So this is a good height to do that you have enough space for the new commissure, because the new commissure at the end will sit a little bit higher than the older one. So you have to be sure that you have enough room to implant that properly. So that's why
Exactly.
you definitely have to follow this rule, not lower than 1.5 centimeter to the right coronary.
Okay. Great. Thank you. Then there's a question about redoing cases. So if you have to redo a case in a small annulus and you can only do Ozaki or a Ross, which material would you use for the AVNeo? Would you use bovine pericardium, photofix,
Photofix.
cardiocell? What would you recommend? Dr. Sanad?
Well, for me, I will recommend Photofix.
Okay. Why?
For the durability, from my point of view.
Have you
We can
used
ask Dr. Crane about his opinion about that. He have more experience about something like that.
have you used photofix at all for AVNeo
No,
procedure yet?
I don't do, but I have two patients with for a redo aortic valve intervention. It may be used a Photofix.
Okay.
I may have some experiences in the near future. Yeah.
Okay. Professor Krane, do you have anything to add?
I have no good candidate for that, because all of them, cardiocell and so on, all of them has their disadvantages. None of them are free of calcification and so on. So I don't know. I can't recommend one of them. If you want to do an Ozaki because of perhaps an increased opening area in these patients, then you can choose the one or the other. Probably also the data which are out there are not that good that you can really say use the one or the other. The Photofix is a little bit newer. Cardiocell, we have our own publication on that its calcification are there. So there's not an optimal material which you can use beside autologous pericardium. And of course, nobody knows if this is ideal.
Yes, of course. Okay, a couple more questions. We have five more minutes to go. Are there any limitations to do the AVNeo, such as the size of the aortic annulus?
For me, I don't think there is no limitation. I perform the Ozaki in two patients. One patient has a bicuspid valve and have a supra-aortic stenosis. This patient have a difficult approach to the valve, but although this difficult approach, I have complete Ozaki. This is the first patient. And second patient, we have a small annulus, 1.9, and I do also Ozaki for them. Difficult exposure, it may be something difficult, but it can be with the help of your assistant, just to pull more much to the annulus and perform a good exposure to you, that you can do everything. It maybe have some high gradient than the good annulus or the larger annulus, but I think the gradient will come down with time.
Okay, Professor Krane?
Yeah, so this is a question which comes from people who are operating on pediatric cases. So what is the lowest limit for the annulus to be? And as you know, I have a little bit easy calculation how the leaflet size should be. So if you measure the annulus with an Heger sizer, so the diameter, and the Heger sizer tells you it is whatever 21, then you usually have 3 leaflets which are 25 or 23, 25, something like that. And if it's almost 3 to 5 to add to the Heger sizer measurement of the annulus. So if you go with this rule and the smallest leaflet on your template is 13, then you can treat an annulus of a diameter of 1 centimeter. So that's the theory behind that. But this gives you something like that you can almost treat every kind of annulus which is given by nature for that, which should be treated. So no reason for limits.
I think Dr. Baird and Dr. Del Nido have a good series for the Ozaki procedure in the aortic in the pediatric group, and
Yes.
they are doing some surgeries, some patients, maybe as you say, Dr. Clint, with 13 size or something like that.
Yes.
Yes.
Yeah, there's a good publication that just came out from Boston Children's Hospital, which talks about very small annulus sizes and some of the work that they're doing to even enlarge the root in order to put in a little bit bigger valve. Okay, final question for both Dr. Sinat and for Professor Krane is with the obviously lots of TAVR procedures being done in young candidates, and a lot of cardiac surgeons are being requested to do more minimally invasive procedures. Do you have any experience harvesting the pericardium using minimally invasive technique? And would you consider substituting the autologous pericardium for a bovine pericardium to actually simplify the procedure?
For me, as regard the minimally invasive technique, I put a plan just to start the minimally invasive in the Ozaki operation by using, by help of our colleagues which are doing VATS. They will help me just to sacrifice a good piece of pericardium, of the native pericardium, either through by two approaches, either bilateral approaches through the thoracotomy, or subxiphoidal approach. We are putting a plan just to start something and get a larger piece of the pericardium, either whether using both approaches or subxiphoidal approach is enough. This is for the minimally invasive technique. For the bovine pericardium, I have a concern about the early calcification and degeneration of the bovine pericardium. So I do not recommend just to use it, especially in our early results or series.
And Professor Krane?
Yeah, so there are different surgeons out there who are doing already the Ozaki procedure or the AVNeo procedure in a minimal invasive technique. So it's definitely doable. There's, I guess, a huge series of more than 120 cases out there coming from Vietnam. Correct me, Damon, but I guess it's his series.
Yep.
So it's definitely possible and reproducible to do that. I never did it so far, but we are also thinking about that. Two things which argue a little bit against that is if you harvest the pericardium minimal invasive, then you will harvest mainly the upper part of the pericardium, which is a little bit thinner. in the thicker part of the pericardium, which is more to the diaphragm, this probably is not sufficiently reached if you do that endoscopically, or at least it's more difficult to get this part. But Ozaki is recommending that especially from this part, you should do the larger leaflets because it's a little bit stronger. So this brings us back to the discussion to the quality of the pericardium, which part to be used, are you able to harvest enough? So far we didn't do it, it's doable, it's reproducible. The second what argues a little bit against that is that around 40 to 45% of our patients has concomitant procedures. So if you have a population who has a mean age of 55 or 50 years, it's bicuspid valves. If you are doing that, then usually or often you have to replace the ascending aorta and so on. So this makes it additional difficult to do the majority of cases minimal invasive. But of course you have to think about that. This would be ideal if you can do the procedure minimal invasive. And of course, we will also try to do that in the future.
But Dr. Crane, I think the minimally invasive now try to convince the patient that the mechanical valve is more better than the Ozaki or the biological or than the Ozaki due to that the wound will be much smaller than that than the one of the Ozaki. So we have to do some effort just to start Ozaki with in the suitable patients candidate only for AVR through the minimally invasive approach. I think that.
Yeah, you have to go minimal invasive.
Yeah, that's something to consider as another topic for the future. So
For another one.
yeah, absolutely. So we're out of time now. So again, I want to thank Dr. Fukuhara, Dr. Sanad, and Professor Crane for their excellent presentations and questions and answer period. I think it was very, very beneficial for everybody online. Got a lot of great comments from people that were joining in the chat. So many thanks to our three presenters. And many thanks to everybody that came out on a Saturday. And as Dr. Sanad mentioned earlier, I hope everybody continues to stay safe during this COVID crisis that we're experiencing once again. So please stay safe, and I appreciate your time, and you will hear more from us in the future. So thank you very much. Appreciate you joining.
Thank you very much. Goodbye. Have a nice weekend.
Thanks.
Have a nice day. Thank you.